Today we have Dr. Wilson Agbavo. He's a specialist in obstetrics and gynecology. When I say obstetrics and gynecology, they are the doctors that deal with women, pregnancy. I mean, everything women, he's in charge. If you see him, you should see women. Welcome, doctor.
Thank you.
Welcome to the channel.
Thank you.
All right. So today we are discussing PCOS. PCOS stands for Polycystic Ovarian Syndrome. So since we have our senior doctor here, he will tell us something about PCOS. Doc, can you tell us something about PCOS? What is PCOS?
I think basically you started it. So, Polycystic Ovarian Syndrome. Syndrome means a lot of conditions comes together to make this disease. That's why we call it syndrome. But the beginning part says polycystic ovarian. So this disease is kindly, let me say, originating from the ovary, where the eggs are released from. For women to undergo their monthly or cyclical ovulation and menstruation. So that is where the problem is coming from, the ovary. So that ovary tend to have certain cysts or small balloons forming inside it. And once it becomes numerous, then that's when we said it is poly. Poly means plenty. So polycystic ovary. So basically that's just the explanation. But now, what does it come up with when we say there's polycystic ovarian syndrome? So basically, that means these women are not actually releasing eggs. So the eggs were supposed to come out. So every single month, a lot of small balloons are being produced within the ovary. We call them the follicles. So they start selecting them, then they'll be growing, increasing in size. Then by the time they are reaching ovulation, one of them will be picked out, becomes larger, burst, and release the egg. Basically, that's it. But unfortunately for these people, this doesn't happen. These follicles, or the small balloons I'm talking about, starts growing, increasing in size, then gets arrested. And they just stay there. They will never release the egg.
So they'll just be there.
They will just be there, intact. Then the following month, another group is selected. They also get arrested. They stay like that. Then it becomes plenty.
So they have a lot of cysts that have not been released.
The eggs have not been released. They are just intact. They are just in there. So they tend to have an ovulation. They don't ovulate. Basically, that's all that's about polycystic ovarian syndrome.
But doc, how do they get this problem? How is it that for some particular people, their eggs are not being released and it's arrested, it's not being released? What's the issue?
Well, there are lots of contributing factors, but they have a very strong genetic predisposition. So if your family, let's say, there's somebody who already have polycystic ovarian syndrome, it means there is a high chance of maybe the sister or the child that will be giving birth to may also suffer from that. So they have a very strong genetic predisposition. Then the other one will be other lifestyle modifications. So probably somebody who is obese. It doesn't mean that only big people get polycystic. Even very lean person, normal body habitus can still have it. So as I said at the beginning, they have a very strong genetic predisposition, basically. But sometimes lifestyle changes can also bring about this polycystic ovarian syndrome.
So what are the lifestyle changes aside the obesity? Because some people are naturally obese. They don't do anything to become obese. So what else? What else make it?
So once you are not probably exercising well, taking a lot of the junk food, you can't take it, but exercise at least, to minimize the level of fat that will be within your system.
Doc, what do you mean by junk food? Because right now, we don't really know which foods are junk. We can take Indomie and we think it's healthy for us. We can take noodles and we think it's healthy for us. We can take ice cream, we can take loaded fries. Can you be specific?
It's all about balance. Life is all about balance, basically. So if you are always taking in, as you mentioned, the fries, the pizza, shawarma, those are what we usually refer to as the junk food. You can actually take them, but take them in moderation. Not every day. That's not what you are feeding on, basically. So that's how come we'll get there. But as part of the management, we usually always, as a first line of management, is lifestyle modification. Always about exercise, about diet. Those two are very strong for us. Because once you're able to do that and probably lose some weight, 5 to 10%, mostly it resolves the problem.
Okay.
Mostly, it resolves the problem.
Wow.
So a lot of lifestyle changes comes at play.
Okay.
So basically, that's polycystic ovarian syndrome. But then, I think now let's go back. So how then do they present?
Okay.
Or what are the things that happen for you to suspect somebody probably have polycystic ovarian syndrome? Yes. So one is either they are missing their period.
All right.
So they will come with a complaint that for the past 3 months, I've not seen my menstrual flow. Or for the last 1 year, my menstrual flow has been very minimal, like slow flow. There's some small quantity that comes out for a day or two, or even for the 5 days. It's just very scanty. My one part does not even get fully soaked. It just gets stained. So usually we will call it oligomenorrhea. Or amenorrhea. That means they are not even menstruating at all. So they can have that imbalance going on for a period, and they will report to you that it's concerning to them. And once you hear this, then you pause. Are they pregnant, or they have polycystic ovarian syndrome, or they have some ovulatory problem? So you just question yourself like that. Then you now go in and look for other features. Okay. So when those features are now added together, then you can now confidently put as first line diagnosis polycystic ovarian syndrome. So first, how they present to you, that I've been missing my period for long, and then I'll flow heavily. Then after 2 or 3 months, it ceases again. It takes almost 2, 3, 4, 5 months later before another flow will come. So that's how they will present to you. Or I'm having a lot of facial hair as a woman. I'm having beard.
Okay.
I'm having a lot of acne, especially when I'm about to either menstruate. I see a lot of acne on my face. I don't seem to like it. So they will come with some of this complaint, basically. So once they present with this, or others don't feel like there's anything wrong with them. Just that they are trying to get pregnant. Pregnancy is not coming. So that's their concern. When they show up, then probably you may end up picking some extra symptoms and signs, then you add them together and make the diagnosis.
So, Doc, you are saying that there are some people that have this PCOS condition, but then they don't show anything. They have a normal menstruation. They don't show any facial hair. Oh, wow.
Everything is fine. But mostly, majority of them will tend to have this low menstrual flow or absent menstrual flow. Majority of them.
Okay.
If you take almost, let's say, every 10 women, one of them will be suffering from PCOS.
Okay. Doc, I want to ask, the facial hair and the acne, is it so typical to PCOS? Because usually when people see people with facial hair, they start the stigma. They will like, hey, you have PCOS. Can you please explain to us?
No, so it's not typical to them only. Other conditions can come with PCOS.
Okay.
Like congenital adrenal hyperplasia can present with facial hair. Somebody can actually just be having like hairy body, like hirsutism is all over their body. Okay. Right? They inherited it from their father or their mother. So it doesn't mean that once you have facial hair or you're very hairy as a lady, it means you have PCOS. Okay. If you actually watch around, you see a lot of people with facial hair, but they are fine. There's nothing wrong. They are okay. They are moving about. But yes, when you see it, you should think of PCOS. It doesn't matter they have. You can think about it. Then you can now look for all the other things. Now, when it comes to the doctors, then they will now make the diagnosis. And making the diagnosis, they look out for we call it the Rotterdam criteria. So there's a criteria that we look at. First, is this person having an ovulation? So period of amenorrhea or oligomenorrhea. Then you take that one. So there are 3 factors we are looking at.
Okay.
So the second one, are they having these hyperandrogenism symptoms or signs?
What's hyperandrogenism?
So it's like there are some hormones that we have in our system. For example, testosterone.
Okay.
So those ones. So hormones. So they are hormones. So sometimes they are very high. They contribute to this hirsutism and co.
Okay.
Then the high acne.
You mentioned
hirsutism. I keep mentioning it, but if you have plenty hair, that's all.
Okay. So hirsutism means you have plenty hair.
Basically, layman's term. When it comes to medicine, we have specific definition for it, but that's not a side for it.
Okay.
Yes. Example, somebody see me and say, I'm very hairy, so I have hirsutism. So when you see some of this, they are very hairy, have beard growing up, or even their hairline is receding, we call it alopecia.
In the females.
In the females. Everything we're talking about right now is about the female.
They have hairline.
Hairline receding. So alopecia. They also play alopecia. Some of them. or a lot of acne during their menstrual flow and all that. So once you pick that one too, you can take it.
All right.
Then the last one is imaging.
Imaging.
Yes.
Photography.
So no photography. So yeah, we have ultrasound scan.
Okay.
So we'll do ultrasound scan of the pelvic area for the woman.
All right.
Looking at the ovaries.
Okay,
There are
so,
two,
all right.
left and right. So they look at them. And then this cyst, polycystic, this small balloons I spoke about in the beginning. Yes, we look out for them. Then you will see. It's normal to have this small cyst.
Okay.
Actually, based on the time of their menstrual cycle, you will get them.
All right.
But we are now looking at how many are they?
How many are they?
Are they a lot? Technically, when it comes to the medical side, for us to give you a mark, if you are explaining it, we will say that make sure there are about 20 of those cysts. 20 or more of those cysts. And even their size should be around 2 to 9 millimeters.
Okay.
Then when we see that, then okay, indeed they have a polycystic morphology of the ovary. So if that one is there, we'll take it.
Okay.
So any of these two categories, the symptoms of not menstruating or having very low menstrual flow, who will define that? Not you, because you are menstruating for 2 or 3 days. You think you have, no, it doesn't mean that you have. Who will define that?
So it's left for the doctors to define.
To decide. You can pick it up and say, hey, am I having it? Then you come forward to the doctors and then we'll investigate further and tell you that, oh, you're fine. There's no problem. Or, yes, indeed, you're having polycystic ovarian syndrome. Okay. So that's in terms of symptoms. Then in terms of the sign or even symptoms again, we'll talk about the hairlines, the plenty hairs, the acne's happening. Okay. So if you're having any of those features too, we will take it. So that's the second category. The last category is about the ultrasound scan that we will do. If you have a lot of those polycystic or the small balloons, then we'll take it. So once any of these two categories are present, then high on our table is we have polycystic ovarian syndrome. Okay. Before we start thinking of other differentials that could also be, if I say differential means possible diagnosis that we can make for you except the polycystic ovarian syndrome. Okay.
So if you find this thing, I want to know, is PCOS contagious? Can you give it to someone? Because some people will be like, oh, you have PCOS, I cannot eat with you. Otherwise, I'll have no one to pick.
No, it's not communicable. Okay. You can't transfer it to anybody. No, it's not contagious at all. Right. No.
So if you have
PCOS,
very fine,
they are very normal. There's nothing wrong with them.
You said they are very normal.
They are very normal.
PCOS.
Like in terms of infection.
Oh, okay.
No.
Okay.
But yes, the condition itself. And even when it comes to the condition, there are things that once you make that diagnosis, we the healthcare workers are worried for the patient. Wow. So usually I put it into two. Things that the patient is worried about. And then two, what we the healthcare workers are worried for the patient. Okay. Once you make your diagnosis that they have polycystic ovarian syndrome, there are things that you must tell them that you are worried about for them.
You must tell the patient.
Yes.
Want to scare the patient.
So it all depends on how you present it to them. Everything can kind of scare patients. So always your delivery to the patient matters a lot. Matters. That it will alleviate their anxiety. Okay. Because once somebody said, hey, I've been diagnosed with PCOS, polycystic ovarian syndrome, their life has come to an end and they are worried and they are stigmatized. So always quickly have to downplay all those things for them.
Yeah, but no, they shouldn't be worried. They're always worried. And if I've gotten PCOS, it means that my life has ended. Yeah. I'm not able to go. I can't give birth again. My in-law is going to say I'm barren. I can't even get married again and all. Yes. Sometimes the boys too make it worse because they don't understand it. Yeah. So
I'm glad we are here today to demystify those kind of things that most people have and then the worries that they have. We are not saying that there are no problems. There are problems, but they are not problems that we cannot help out with. All right. There are lots of PCOS people around. Example, with infertility. Okay. Now have kids. All right. They are fine. Moving around. Once they follow the regimen of management, they are good. They are good. There's no big deal to it. The major concern over here is diabetes. Okay. Type 2 diabetes. They can easily develop that. A lot of the pathophysiology or how the problem comes about revolves around insulin resistance. But let's throw that one away. All right. So the worry is they might develop type 2 diabetes. Okay. 2, they might develop hypertension. Okay. They might develop some heart conditions. Okay. Yeah, some heart diseases can come up. So some of these things is what you are worried about for them, basically.
All right.
So you let them know that your cholesterol level can go high. And once it goes high, it's a syndrome. As I said, polycystic ovarian syndrome. So these things
are coming
in. So when you pick these things up, it forms part of the syndrome.
Okay.
So quickly, even if they don't have it, let them know that it can come up. Therefore, this is what we are going to do
for you
to prevent it, or if you already have it, to manage it. Now, let's take the person who comes to you.
All right.
I'm not menstruating like every other lady menstruates every single month. That is the concern of the patient. You don't go being worried about the fact that there will be infertility.
Okay.
You're not able to give birth. Then you're telling that, oh, you might become barren and all that. That's not why she's there. Why she came. So don't bother about that.
All right.
Why is she here? A menstrual flow. So you just help them get a regular menstrual flow.
All right.
Good. Once you treat them, somebody will come. I'm having a lot of acne. You help manage the acne for them. You don't go about fishing and looking at other things.
So Doc, most of the ladies having acne and buying all sorts of cream may somehow have PCOS. But because they don't know, they are just treating the surface.
Yeah, having acne doesn't mean that you have PCOS.
Okay.
It's possible you may have, but a lot of us, even guys, can we have a lot of acne sometimes. I mean, I have PCOS.
So you understand, having acne doesn't mean you have PCOS. Don't go and stigmatize someone who has acne. Are you there?
All right. Sometimes the androgens level that are very high causes, so especially for we the guys, we have lots of testosterone.
All right.
So it increases this facial hair that we have. That's why we have lots of facial hair because of testosterone.
Okay.
And then some of the acne also show up. So women that tend to have some increased level of testosterone tend to have the facial hair, the hirsutism, the acne, yes. So sometimes your targeted treatment is based on what is causing all this. You just focus on why they are here. A lot of hair. All right, treat that for them. If it's clippers or waxing or laser therapy you are going to do, or offer them some medication, basically that's what you do. You focus on that and manage it for them. Because let's say a 25-year-old let's say a 22-year-old comes to you unmarried, is not bothered about getting pregnant and all that. But is concerned that my menstrual flow is not coming every month. You just focus on that. But let them know of the possible complications that can come up. As we said, diabetes, hypertension, heart diseases, high levels of cholesterol that we call dyslipidemia, those things can come up. So you let them know, and then what they should be doing in terms of lifestyle modification. Period. We are good.
All right.
Basically. So yes, that is PCOS.
Okay, so Doc, let's see. Right now, most of the youth, their concern is their menstrual flow. Most of them will be like, oh, I've not menstruated for the past 3 months, 6 months, even the year. I've just menstruated twice. And then sometimes they do. So those people, they do pregnancy tests a lot. I mean, those that are sexually active. Because imagine you going to do the thing and then now you can't see you can't see your menses and you are torn between getting pregnant and the others. So what do doctors do for these people? Is there a way that they can see their menses regularly, or it shouldn't be a bother?
Okay. Yes. So I like the fact that they'll go and do pregnancy tests. That's one of our first differentials.
Okay. I know, right?
What else could it be aside PCOS? Somebody comes, yes, I've been having this irregular menstrual flow for a long time now. But once they show up to you that, oh, I've not seen my menstrual flow for the past 3 months, and it's been happening for some years now, your first thinking should be, they could be pregnant. So always rule out pregnancy.
All right.
So it's good some of them have to check. But I'm assuming that they're having safe sexual practices.
I'm also assuming. Okay.
Yeah, so if their concern is about the menstrual flow not coming monthly like their other colleagues, yes, as clearly said, those small balloons that we call the follicles get arrested. And then the egg is not released. So there's no ovulation. And mostly when there's no ovulation, there is a certain hormone. So the hormones is always about balance. So estrogen, progesterone, when it comes to the women, plays a lot of major role when it comes to their menstrual cycle. So it's about that balance that causes when they should bleed and when they should not bleed. Now, these follicles, when one of them is selected, that we call the matured follicle, and then it releases the egg there's a high production of progesterone, the other hormone.
Okay.
So once the level of progesterone goes up, it stabilizes the inside of the womb.
Mm-hmm.
But once there's no pregnancy, it starts going down.
Okay.
So once it starts going down, that stability for the womb is no more there. So that lining inside the womb breaks down and comes out as their menstrual flow.
Wow.
So that means that is where, the trick is.
Okay.
So if you're able to target that hormone that is not going up to stabilize and then go down for the menstrual flow to come, just target that. So now we come in and introduce that hormone externally.
Okay.
To these ladies who are concerned about their menstrual flow not coming regularly.
Mm-hmm.
Where the progesterone.
Okay.
So once we give it to them, we have in different forms. So when they come, we'll have questions, and then once you think we qualify, we give you the medication. Or we give you the cyclical contraceptives, so the combined oral contraceptives. We give it to you in a pattern that will not regularize your menstrual flow. Usually after some 2 or 3 months, your system gets readjusted. Then we will draw it. Then your system will continue making it come regularly.
So after they've taken usually after they've taken the contraceptives, the system kicks back in.
Yeah, sometimes just jump starting the system. So we'll do it for 2 or 3 months. Then we'll draw it and see.
Okay.
Can it be okay? Sometimes it might fail. You go back to the state again of not menstruating regularly as you should. But yes, some people it works perfectly for them.
So I had a question.
Basic ways.
Beautiful. I had a question from at least some anonymous messages, and I had a question on this. I mean, we're not talking about contraceptives now. Yeah. But to clear the air, most people don't want to take the contraceptives given to them because they believe it has so many side effects. Some say to give them cancer, it's going to make them obese, it's going to make them more infertile. I mean, it's a whole lot. So, Doc, can you just clarify this one so that we move on with that?
Oh, yeah. Every medication, be it the tablets, the pills, or the syrups, or the suspensions that you take, or even blood is a drug. Everything has side effects. Basically. So when we are making treatments or we are managing somebody with a particular medication, we are weighing the merits and the demerits. And how often does the side effects actually come? Most people will not suffer from it, basically. So they are there. But when it comes to contraceptives, especially using it for PCOS individuals to regularize the menstrual flow, before I even explain this further, you're not menstruating. So that means you're not breaking down the lining of your womb. It's just growing, growing. There's this condition that we call endometrial hyperplasia. It means it's just overgrowing, basically. Now, this overgrowth sometimes can result into one of those overgrowth going haywire and becoming cancerous.
Oh, wow.
Over a long period of time. All right. So as I was saying, that's when we talk about the ladies not menstruating often. Basically said, menstruation means the lining of their womb has grown, has developed a little, got stabilized, and there was no pregnancy. So they break down and come out as menstrual flow. Good. Now, for those who are having this irregular menstrual flow, a period of whereby they don't menstruate, it means this growth is just going on. It's not being stabilized and then later break down. So the more those linings are just growing up and not coming out, one of them can go haywire. And then endometrial cancer will come. All right, good. So we are saying this combined oral contraceptives or contraceptives that we usually give to them rather helps them to break down this lining. So the more you're breaking down the lining, the less the risk of developing endometrial cancer. So it's actually in a way beneficial and reduces the risk of developing endometrial cancer in this group of people, of women.
So it helps you reduce your risk.
No, it doesn't mean that. This is how we are treated. Treatment being done, and then we are saying this is the benefits that comes along with it. Yes, there's some people that will not qualify for us to actually use the polycystic, for us to use the contraceptives. So those groups are also there. So always, anytime we're going to use any of the contraceptives, you weigh them, whether you are medically eligible for us to give it to you. or not. Yeah, so we'll go through all those things probably in the next series when it comes to contraceptives. Yeah, so contraceptives are basically fine in this group. It's good for them. As for the weight gain, no, they don't. It actually doesn't cause weight gain.
Oh, really?
I know that myth is there that always it causes them to have weight gain. No, it doesn't usually cause them to have weight gain.
Okay.
Like whatever even happens is very negligible. So we don't attribute it to the hormonal contraceptives, basically.
Beautiful, beautiful. So we've talked about regularizing their menstrual cycle.
Yes.
What about those that want to give birth? Is there also an option? Because most people have in their mind that the moment you say PCOS now, infertility.
I agree. And then the first question you asked, you pushed me directly to the contraceptives.
Okay.
But let me rewind.
All right.
When it comes to managing polycystic ovarian syndrome, independent of whatever condition that you come up with, like symptoms that you present or concern that you are up with, whether it is you're not menstruating frequently, or you're unable to give birth, or you're having a lot of acne, or a lot of hair, facial hair, and all that, the first line treatment is lifestyle modification.
Beautiful.
Always.
Okay.
Sometimes you can just do that and then everything gets resolved. Oh, wow. And they are fine to go. You don't have to put them on any pharmacological, management.
Okay.
So non-pharmacological. You come, all
nice.
Right, we'll send you to the dietitian that this is what is wrong with you. We've diagnosed PCOS. So they should give you advice on your diet tailored to your condition. So we'll do some investigations and add to it before you go to them. So once they see that, then they will now advise you because they've also been trained over the past 4 years as a degree in how to manage some of these conditions using diets. So they will give you the advice. And once you follow that, then it might help. Then also exercise.
Okay.
The exercise too is not like giddy exercise, so simple exercise.
So what do you mean by
like daily aerobic exercise, even if it's skipping. You are doing, rope skipping for every day, just 30 minutes.
Okay.
30 minutes for at worst, if not for the entire 7 days, 4 days out of the week. That alone is also good. Of course, if you also go to the physiotherapist or the physical science people, I'm sure they're able to help in those. So, but all put together, once you're able to go on the diet and the exercise regimen, and you lose about 5 to 10% of your weight.
Oh, okay. So the main goal is to lose weight.
Yeah, the main goal, especially those who have extra weight.
Okay.
It doesn't mean that some people are lean, but you don't go asking them to also lose weight. They're already lean.
Okay.
But they can also suffer from PCOS. But most people have some extra weight gain.
Okay.
So you just have to drop it by some 5 to 10%. And mostly the condition just reverses and then they are good to go. So yes, so that's the first line management for everybody, for every concern they have.
Lifestyle modification.
Basically. Now let's come to the question you asked. Those who probably, let's say we do this lifestyle modification and then they still didn't help them in getting pregnant. There's lots of things to say.
Say it all.
Yes, medicine. Yeah. The fear with the general public is once you say one thing, they hold on to it. Okay. But they are interlinked. Okay. That's how come we went to school for the past 6 years and still going to school for additional 3 years. And still just, lifelong learning. Is able to help decipher things very well. But when you say, once you do this lifestyle modification, you lose like 5 to 10% of your weight and we think you might be good. Everything might resolve, but you might still not get pregnant. Okay. Because there are various factors that comes together for a woman to get pregnant. The first thing is you must have sex. All right. Unprotected sex. Okay. Then sperm will be released. And then hopefully we are saying egg 2 has been released. And then they will pass through all the passageway, go through the tube, and then they will meet. Then they will form pregnancy. Basically. So we are assuming that every other thing is normal. The only thing that is not happening in this couple's life or those who are trying to get pregnant, these partners that are trying to get pregnant, before the only problem is the woman is not releasing egg. That's what we are saying in this situation. That means we ruled out every other possible causes of infertility for this woman. And we've zoned on just on the PCOS. And that's what is causing her not to have pregnancy. So now the job is, let's make her release the egg. And we started from the lifestyle. If it works, great, we are done. Our job is done. But if it doesn't work, Then we now go to the medications. So you have some medication. Example, letrozole. Then we have clomiphene citrates. Sometimes people, in the olden days, they do some drilling. They go into the abdomen, go to where the egg is, do some drilling there, and then it stimulates the follicles or these small balloons to be releasing the egg. Or you go and cut part of the ovary where the eggs come from. And also, by now, we've stopped doing those things. Now, the leading one is the lifestyle modification, then followed by the medication as I've mentioned, the letrozole,
so the
clomiphene citrates.
So the function of the medication you are giving is to help the
woman to release the egg. That's all that we are trying to achieve here. We are assuming that every other factor is normal.
So if the woman release eggs, if they release the egg, will they have menstruation, or they can release eggs and still not menstruate?
So once they release the egg, as I said, when the egg is released, the balloon that has released the egg, technically we call it follicle, that has released the egg, now starts producing a lot of progesterone. That hormone helps in balancing the endometrial growth. Then later, if there's no pregnancy, that follicle that has released the egg dies off. So that means there's no more progesterone production. That's supposed to stabilize the lining of the womb. So once it is no more there, it will break down and come out as menstrual flow. So means once you cause a woman to ovulate, most likely they are going to menstruate regularly. But when it comes to the combined contraceptive that we are giving, we are just mimicking, we are externally giving the medication. So we don't need them to ovulate. And the combined oral contraceptive, of course, will prevent you from ovulating. Because it's serving as a means of regularizing your menstrual flow. And it's also serving as a contraceptive that's preventing you from releasing egg and getting pregnant. So this one, you don't need the egg to be released for that follicle or that balloon to start producing the progesterone for it to cause a stabilization and a breakdown. Already, we are giving you the medication, so you don't need that to happen. We are giving it externally. So it will go and cause balances in your system and will cause that breakdown to menstruate nicely. So always, there must be a goal when you're managing these patients. Why are they here? So you manage that for them. And then what you're worried about for them, you speak to them about it. If you have to be doing follow-up, like checking if their sugars are okay, if they are going high, then probably you have to start some medication or some extra management. So it's part of the treatments when it comes to those suffering from that. So always, it's targeted to the patient. It's not generalized that every polycystic ovarian syndrome patient that comes, this is how you manage them. No. It is what the patient is here for. You manage it accordingly alongside your guided therapy.
People want to know what food. I mean, you mentioned a dietitian, but you're a doctor, you're a senior doctor. Yes, they want to hear from you.
I'm a dietitian.
So they're saying, you mentioned junk foods too, but then can you tell us food that make PCOS better or makes PCOS worse? Maybe you can group them, so make PCOS better, because people want to know how can they eat well.
Eat well, they should eat well, just cook food. No, so basically, like I said, we don't have specific food. Example, if you're taking banquet, cotomre, that is what will help you improve the PCOS or not. No, we don't have specific food. That if you take and then PCOS will improve or PCOS will get worse or you develop PCOS. All that we are saying is your weight should be checked. You shouldn't be so much fat in your system. The more the fat builds, some of these hormones we are saying, they feed on or they are produced from the fats. So the higher the fats, the higher they are being produced, and then they start circulating in the woman's body. And then it now causes this imbalance and later results into the anovulation, as in the woman not being able to release the egg. Then all the syndromes follow. So there's no specific food that will take and say, oh, this one will help you with PCOS or will worsen your PCOS or will bring PCOS onto your life. No. So it's just, as we are saying, the dietitian will come in that, oh, you should have your 7-star dish, the balanced meal and all that. We're not saying you should not take pizza. You can take pizza.
You can take pizza.
Why can't you take pizza? Chill. You must enjoy your muff.
But
you must balance.
Balance
Too much
it.
of everything is bad. So once you balance things out, you are good to go.
Okay. So I also have, but before that, I also have a question. But before that, I want to ask, what one myth about PCOS would you want to correct? What one myth about PCOS would you want to correct?
Yes, this one is common. Okay, I think I'll give two.
All right, give us two.
One, they say, oh, those who are fat are the ones who have PCOS.
Okay.
There's
It's
nothing
not true.
like that. Anybody of any body type can develop PCOS.
But Doc, you mentioned obesity as a risk
Yes,
factor.
I say it's a risk factor. Risk
Okay.
factor doesn't mean that it is what causes it.
Okay.
The people who are obese they don't have PCOS.
Oh, okay.
They are very fine.
They are very fine.
Anytime we say risk factor, example, we say, oh, smoking cigarettes is a risk factor for lung cancer. So they have smoked their entire life, have developed lung cancer. But we are saying when we take a cohort of smokers, let's say we take 100 of them, of those who are smoking, then we take 100 of those who are not smoking, and every other factor is the same for them. When you follow them over a period of time, majority of lung cancers that you get will be in the cohort of those who are smoking.
All right.
Then, but you still get some lung cancers in those who are also not smoking. That means if you're getting most people from the group of smokers, it means smoking is a risk factor. Okay. Doesn't mean that once you are smoking, you will get lung cancer. But once you are wise enough, hey, it's true. Am I part of that cohort that might develop there? Because it means I'm increasing my risk of getting it. So let me stop.
Okay.
You can also be there, you not take anything,
and then you still get
cancer. But at least it's better you are on the safer side. The majority of you who are not smoking will most likely not get it. So you rather play in there. If nature still ends badly with you, no problem. At least you've done your best. It's better to avoid when you're seeing the hot knife that it won't cut you and run across. Then stay back. You don't run across it. Basically, that's it. So yes, obesity is not a cause. It's just a risk factor, basically. So that's what I'm saying. Anybody of any body habitus, whether the regular, the lean, or the large, can develop PCOS. Basically. So there's a myth that has to be taken away from our brains. Then also, once you have PCOS, you can't give birth. No. Yes, but we are saying most of the complications, and I mentioned them, the type 2 diabetes, the hypertension, the heart diseases, high level of cholesterol in your system, infertility. Those are things that we are saying complicates the polycystic ovarian syndrome. And majority of them, about 70% of those who have PCOS, will have infertility. But once we diagnose PCOS, does not mean you are infertile. No, the people who have PCOS and nobody has touched them and they've gotten pregnant, delivered, everything is fine. I see them daily. Some people come with their beard, with their egg, and they've got nicely pregnant. So it's a myth. You rather come, check until you attempt to get pregnant and you're not getting pregnant over the defined period. Then we can now say, oh, infertility has set in because of the polycystic ovarian syndrome. But being diagnosed with polycystic ovarian syndrome doesn't mean that you have infertility. So that's another myth probably.
Have you heard? All right. Since we are coming to the end of the conversation, I want to ask this last question, Doc. Does PCOS have a cure? Is it curable?
Is it curable?
Is PCOS curable? Can you cure it completely?
What do we say? Okay, so as clearly said, PCOS is more of like hormonal imbalance. So once we are able to balance it, maybe that's a cure.
All right. That's nice.
Yeah, basically.
So once you're able to balance the
hormones, basically, I think you are well managed. So you just have to balance it. And the balancing can be from your own activities, lifestyle modification, through exercise, diet. And we are done. The job is done. We are all seated back. But yes, if the complications comes, we are there to get them treated or solved or managed. Basically.
So PCOS is not as deadly or a death sentence as people put it.
As I said, if you take nearly every 10 women, one of them have PCOS. So
every 10 women.
We have a lot of people with PCOS.
So you're not alone.
about 10 to 15% of people, based on the jurisdiction that you are in, either in Ghana, West Africa, or China or Asia, it varies in terms of the incidence rate.
Okay.
It varies. But about 10 to 15% of people are living with PCOS.
All right.
So it's quite a number.
Yeah.
But everybody's still moving around fine.
They're giving birth.
They're giving birth. So it's not a death sentence to anybody at all. Yes.
All right.
And there are varied forms of it. But that one is for the doctors and the medical students.
Yeah. So the last question. People with PCOS, can they take alcohol? Because I keep getting this question a lot. People with, can they take alcohol? Can they be free to take alcohol like any other person?
So the question is alcohol good?
For us, answer that question for us.
It's not just about the PCOS people. Okay. Is alcohol good in general for us? I think recently WHO came out with something saying that no form of alcohol. First we tend to say, in moderation. If it's small, it doesn't really do much.
Yeah.
And especially they even say red wine really helps in heart conditions and all that. It's fair enough. But the recent study shows that any form of alcohol, whether it's
5%,
small, medium, or a binge drinker or whatever it is, it's still not good. So we cannot here be saying that, PCOS people, they can go ahead and take some alcohol to help with the management. No, there's nothing. It has nothing to do with alcohol.
All right.
But yes, the alcohol, of course, is a lifestyle when it comes to diet and all that. So it might play a role in affecting your metabolism. And can lead to hyperlipidemia and other things, and later worsen your condition, basically.
So it's not advisable for anyone to take alcohol.
Once in a while, you can enjoy your but it has no bearing on treating PCOS. It may rather worsen it because, as we said, it's about lifestyle modification.
All right. Thank you very much. Thank you very much, Doc. Yeah, it was very insightful. Yes. Yeah, I really enjoyed this session.